And as Dr. Sugaranjini goes for her talk, uh, the diagnosis of dry eye is basically clinical. One very important, thing that really helps us is the questionnaires, which is something which we generally don't use in our regular practice. Anand is there. Dr. Anand. Yes, you're supposed to come here. Yeah. So the problem is, time consuming. So that is where, the role of optometry team and your dry eye clinic comes into play. And, when you have such a busy OP, it's really difficult to sit and get the questionnaire done. It definitely points us towards a, significant symptomatology. And dry eye is basically managing symptoms, except in very, a small niche of patients. Yeah. Not even minutes. Okay, it can be less than a minute in most of the. Now that's ambiguity here. Okay, we still don't know why it functions so well when we use it. When we say the retention time is so low.
I would like to invite our next speaker. Dr. Sugaranjini is presently working as an associate consultant, cornea and refractive and ocular surface services at Girdhara Institute, Cochin. She has completed her DNB in Narayan Nethralaya and fellowship at Girdhara Hospital. Over to you, Dr. Sugaranjini.
Good morning, everyone. It's heartwarming to see a full hall for a dry eye IC, which we did not believe was possible a couple of years back. And this itself clearly shows that dry eye is evolving into a subspecialty by itself. A dry eye patient is never any ophthalmologist's favorite. So to make my chair time with a dry eye patient a little more interesting, I like to play this game called I Spy with my little eyes with all my dry eye patients, because this is a very common scenario seen in our practice. Most of these patients are mislabeled as dry eye, and as the previous speakers have already beautifully illustrated how to evaluate a dry eye, I would like to show some cases which were mislabeled and not adequately treated for the dry eye symptoms. So my first case today is a 32-year-old female who's a chronic contact lens user, and she gives a history of a recent onset intolerance to contact lenses. Since we have a lot of toys at our disposal right now, we did do her ocular surface analyzer, and you can clearly see that her lipid layer is in red. That means her meibomian glands are not functioning so well, and her non-invasive tear butt is also very low. But she does have a good tear film height. So we did image her meibomian glands, and it is clearly illustrated here that she has meibomian gland losses, which is seen here. The hyperreflective areas are functioning meibomian glands, and some of the meibomian glands are lost. So why does she have such a significant meibomian gland dropout? And as among all the toys that we use, my favorite still is the history taking and the thorough slit lamp examination. So when we did question her about her history, she said recently she started using these retinol cream around her eyes for her wrinkles, started by a dermatologist. And it is very well reported that long-term contact lens use can cause meibomian gland dysfunction, and retinoid cream is also associated with meibomian gland dysfunction. So she was asked to discontinue her, cream for some time, and she did improve really well. A thorough slit lamp examination can really help these patients, and slit lamp examination must not be pertained only to the cornea. It must be a thorough ocular surface examination. So a 45-year-old female presented to us with a dry eye, labeled as dry eye, and she gives a history of thyroid dysfunction. Her thyroid profile was normal. So I would like to ask the audience, is there anything specific that you do for your thyroid patients who present with dry eye? Can anyone point any one particular thing that should not be missed in your thyroid patients? If anybody could volunteer. So in a thyroid patient, my favorite thing to do is to lift their lids. So if you retract their upper lids, most of them do have a superior limbic keratoconjunctivitis. In this picture, you can even see this was taken after the treatment was given. So this is very commonly seen in all thyroid dysfunction patients, and they are often mislabeled as dry eye. And in this patient, we just prescribed her bandage contact lens because she was not keen for a conjunctival cautery. And one clue do is that in a thyroid, even if their thyroid profile is normal, it would be better to check their thyroid receptor antibody test, which is more specific for ocular symptoms. Similarly, a 68-year-old female also labeled as dry eye presented to us, and when we did examine her, can anyone take a quick guess of what this is? Yeah, she does have filamentary keratitis, and when we did look at her as a whole picture, thanks to COVID, all of them come in wearing a mask, and we don't really look at anything beyond their eyes. So when we did look at her, when she actually pulled her shawl a little down, we can see an enlarged thyroid gland here. So every dry eye patient should be examined in total, and most of them are mislabeled as simply dry eye, and a thyroidectomy helped her alleviate of her symptoms. So this is an 81-year-old female who presented to us. She gives history of anti-glaucoma medication since many years. She was referred for a dry eye evaluation, but can anyone see what is, okay, so you can see some subtle subconjunctival scarring in her upper tarsal conjunctiva, and also there is keratinization, and her puncta is completely stenosed, and there's loss of plica also. So she was labeled as drug-induced pseudophemphigoid, more commonly seen with patients who have been using anti-glaucoma medication since many years. So unless you do a detailed slit lamp evaluation, you might miss these subtle signs.
One second, before you go to the next, about that case. See, many of us have the feeling that, when the disc is suspicious, when there is a, dilemma, it's safe to start an anti-glaucoma medication. What is lost? Okay, you put the patient on anti-glaucoma and the patient disappears, and years later present like this. Okay, once they reach this stage, going back is not easy and practically impossible. Okay, so anti-glaucoma medications are not simple, not absolutely safe. Okay, so before you put the patient on any of these medication, there are drugs which is used once a day, there are drugs which is used twice a day. So we may think, it's such a small dose, what is going to cost? But these patients are going to use that drug for years with resultant problems like this. So unless you are absolutely sure that patient needs the drug, please do not start. Okay, we have seen many cases, we have stopped them because they were on, unnecessary treatment. It was absolutely not warranted or required for those patients, but then they develop problems. Okay, so please be careful. And I tell my glaucoma colleagues, they always come at me with a, stick if I tell them, wherever possible, start preservative free. Or according to me, anti-glaucoma medications with preservatives should be banned.
Thank you for that wonderful tip. So, a 60-year-old male presented to us with a foreign body sensation since many years. I would just like to share his photo. Can anyone take a quick guess on what condition he's suffering from? So this is not very commonly seen. Once we retract the upper lid, usually you cannot see the entire fornix. But in his case, where you can see up to the entire fornix of his eye is seen. So this is commonly seen in floppy lids. So this patient is not actually suffering from just dry eye. His lids are floppy. He needs a lid corrective surgery. So I think this illustrates that, just lifting the lid can give out many clues as to what your patient is suffering from. So he was diagnosed with floppy lids, and lid corrective surgery was advised for him. So most of these post-LASIK patients come back to us with dry eye, and we often dispose them with the first lubricant that pops to our head. But not all post-LASIK patients actually have dry eye. This 29-year-old female presented to us with a headache, and she was diagnosed as dry eye. And when we did a complete orthoptic evaluation for her, we found that she had a low AC by A ratio, and she had a receded near point of convergence. And we advised her to use the Brock string and the pencil push-up test, and she improved remarkably. So in your post-LASIK patients, it is important to even do an orthoptic evaluation in spite of them being 6'6", and most of them may not be suffering from just a post-LASIK dry eye. So staining has been used for long in our dry eye practice, and it helps us document and monitor our patients. It also gives us subtle clues based on the type where the staining is actually present. Gives us subtle clues on what could be the etiology. But staining can also help you pick up those patients who've been wrongly labeled as dry eye. So this 58-year-old gentleman presented to us dryness in the left eye more than right eye. Only left eye is his complaint, and this was his clinical picture. Can anyone take a guess as to what you're seeing? You can see some subtle subepithelial dots in the inferior, cornea. And stain is what helped us pick up what it was. When you stain it, you get a negative stain. So this patient is actually suffering from a recurrent corneal erosion syndrome, and on further probing, he did tell us that he did have a history of trauma in this eye. So not every dry eye is actually a dry eye. So we advised alcohol delamination for this patient, and his symptoms remarkably improved. Our next patient is a 65-year-old gentleman who's undergone a cataract surgery 2 months back, and he was referred for visual blurring in the late post-operative period. He was initially 6'6", but then then his vision dropped to 6'36". This is a very common thing encountered by most of our cataract surgeon, and on history taking, he's on multiple eye drops. Just look at the list of the eye drops. He's on steroids, hypersol, tobramycin, and even an AGM. And when we look at the clinical picture, this is basically a surface toxicity induced by the multiple medications. So it is important to understand this by staining. By staining, we can see there's a punctate epithelial erosion of 3+. And we did do a ocular surface analyzer in him and look at his lipid layer thickness. It's completely low, it's in red. And his non-invasive tear breakup time wouldn't be accurate in this case, but looking at his meibomian glands, he already has meibomian dropout. So this is what contributed to such a severe surface toxicity. So in patients, even pre-operatively, before your cataract surgery, it would be advisable, if you do have a meibography, do it to know the meibomian gland health. We prescribed him a course of doxycycline antibiotic, and we reduced by simply reducing the topical medications that he was on. He improved remarkably, and his vision improved to 6/9 within 1 week. And we can see that the PEs are clearing. So as Dr. Iredin has already illustrated the various ways of using our toys, the tear meniscus height is measured by the machine in this way. It measures the distance between the lid to the highest point of the tear film. But we must not simply believe these machines also as it is. So 58-year-old male patient comes to us diagnosed as dry eye since 1 year. Main complaint is watering and foreign body sensation. So we did do the ocular surface analyzer and look at the tear film height. It's in yellow. We very rarely see this. So when you see a very high tear film height, we must remember that the machine measures the tear film height this way. So in this patient, this is what we saw. Can anyone take a guess of what this is? There is, of course, an increased tear film height, but there is something that is causing it. This is just an inferior conjunctival chalasis, which is giving a wrong value for the tear film height. So in a patient of dry eye, if your tear meniscus height is shown to be very high, always look for conjunctival chalasis, and we must not believe these machines blindly. And we advised excision of the conjunctival chalasis, and that remarkably improved the symptoms. Blink rate is a new tool these tools have made it possible for us to analyze the blink rate. And a 22-year-old young male comes to us with dryness, and he gives history of recurrent lid lesions. So when you hear this recurrent lid lesions, your first thought is going to be maybe he gets recurrent styes. So we did do the imaging of the meibomian gland to look for meibomian gland dysfunction. As you can see, his meibomian glands are spectacular. There is no dropouts. His lipid layer is fairly okay, but look at his blink rate. They are really high. They're very high for this patient. And we just put him back on the slit lamp and looked at his slit. I don't know if it's clearly seen. So he had this viral wart. Okay, so this was what was causing this recurrent irritation in him and making him blink a lot more and giving him a feeling of dryness. So a simple removal of the viral wart by excision made him improve. And we do get patients like this, like a 54-year-old female patient who presented to us post a ptosis correction. And this was her clinical picture. This is what you would see in probably a neurotrophic ulcer or a patient with exposure keratopathy. These machines can actually help you diagnose these better. So if you can look at her blink rate, it is nearly nil in both her eyes. And even the 2 or 1 blink that is there, out of that 2 and 1 are partial. So another thing that I would like to highlight is in a patient with a low blink rate, their lipid layer will be falsely high, because as we know, the lids is what spreads this lipid layer across the ocular surface, and when there are no blinks at all, the first recorded lipid layer just remains there, so they will be falsely high. So this patient had a poor blink-induced exposure keratopathy. This can be seen in post-doses correction, and a simple tarsorrhaphy helped her improve her symptoms. Another case on the similar lines is a 30-year-old male patient who presented with severe dryness in the right eye, and he had undergone congenital ptosis correction in the past. And again, look at his blink rate. Most of the right eye, so he has 6 blinks, but out of the 6 are also partial. But look at his lipid layer, it's very falsely high. That is because there is no blink to distribute this. So these are partial blinks induced by secondary to ptosis correction. So this patient is also suffering from a exposure keratopathy. And we do rarely have such patients. A 34-year-old male patient who's a self-proclaimed poor blinker. His complaint was that he has dryness and he knows that he blinks very poorly. And he was true to his word. When we did do the test, his blinks were 0 in both eyes. And again here, I would like to highlight that his lipid layer is falsely high. So you cannot tell this patient that you don't have evaporative dry eye because you have a good lipid layer thickness. So what we did advise this patient is, now we do have blink apps on our phone which can be installed on your phone. So when you're scrolling through your phone, every 30 seconds it gives you an notification that you need to blink. So there are newer tools available to us at our disposal, and we must use it in a toto to help these patients feel better. Thank you very much for your patient listening.
Thank you, Dr. Sugaranjini. That was indeed a potpourri